Hi there, my name is Glenda O'Connor. I'm a senior specialist dietitian at the Wellington Hospital, working in the area of HPB and oncology. So today I'll be taking you through nutrition for the cholangiocarcinoma patient. It's quite a short session that we have today, so I'll be taking you through an overview of the nutritional issues, the key nutritional issues that patients may face when they have a diagnosis of cholangiocarcinoma. So we'll be looking at why nutrition is important, the factors affecting nutritional status overall. We'll be looking at some key issues such as weight loss, cachexia, sarcopenia. We'll be looking at how diet can help manage side effects of anti-cancer treatments as well. There's two conditions that I'd like to discuss today, really because it's more because there can sometimes be a lack of awareness, or there are two conditions that may be underdiagnosed or under-recognized in this patient group. And so I'd like to talk about bile acid malabsorption and small intestinal bacterial overgrowth as well. So moving on, why is nutrition important in cholangiocarcinoma? Nutritional concerns, issues and needs will really vary between patients, and for numerous reasons. It may depend on the stage of diagnosis, how severe their disease is, the types of treatment modalities that they're undergoing, and various factors. So patients can be quite individual as to what their concerns or their questions may be around nutrition. Nutrition is important as well because the systemic effects of cancer will impact nutritional status, and this is something that patients will be up against pretty much ongoing. The side effects of treatment modalities as well can impact nutritional status at a time when patients need nutrition the most, and so this is often under-recognized. Evidence consistently shows that poor nutritional status and malnutrition will negatively affect patient outcomes, particularly tolerance and response to treatment, be it chemotherapy, radiotherapy, or surgery. It'll impact functional status, it'll impact patient quality of life, and overall prognosis as well. So early in diagnosis, patients may be experiencing very few or very vague symptoms such as nausea, maybe a gradual loss of appetite, and these symptoms may not even be recognized when they're happening very, very, very slowly. However, at diagnosis, nutrition-related symptoms may be more severe, and patients may have been experiencing these for quite some time and quite significantly. So it may be that they've had quite a prolonged loss of appetite, maybe significant weight loss that's been slow but steady, abdominal pain, and just a gradual trend towards tiredness, lethargy, which can make meal preparation quite difficult. And so at the point of diagnosis, and when patients are being considered for treatment options, they may already have an impaired nutritional status, and this again may impact their treatment options as a whole. So when we talk about nutritional status, patients are at risk of malnutrition due to this disease effect and the side effects of treatments when they're undergoing treatments. There are a number of factors that can affect nutritional status. Number one is the systemic impact of the disease itself. So cancer can cause a negative energy balance and muscle loss due to a combination of reduced food intake and also these derangements in metabolism. And if there's a trend towards protein breakdown, lipolysis, insulin resistance as well, so caused by primary anorexia, which is central nervous system driven, and also some secondary impairments related to that, which I'll go through in just a minute. These patients as well will often have increased energy needs due to an increased metabolic rate, and so naturally their demands are higher, their need for nutrition is higher as a baseline. So coupled with this disease effect, we also have other factors such as gastrointestinal symptoms that may be impacting intake, poor absorption of nutrients, where there's a malabsorption effect, taste changes, dry mouth, etc. And coupled with this, low mood and fatigue, which again can impact ability just to eat and drink normally. So when we think about nutritional status, one of the key indicators we look at is weight loss. But in patients with cancer, with cholangiocarcinoma as well, this involuntary weight loss is different to non-cancer patients. And we need to consider these terms cachexia and sarcopenia. So cancer cachexia, it's a multifactorial syndrome characterized by an ongoing loss of muscle mass that leads to progressive functional impairment over time. It's a common side effect of advanced or metastatic cancer in particular, and it occurs in approximately 50 to 80% of patients. We know that as little as 2.5% weight loss or body weight loss or more and a low BMI are both independent predictors of survival in this patient group. So it's really important that weight loss or any sorts of changes in weight loss are tackled early on. So cachexia is driven by this appetite suppression due to catabolic drivers that are cancer derived, and coupled with a reduced food intake and abnormal metabolism. And what you get is a progressive involuntary weight loss over time, muscle wasting, again, this fatigue that begins to build up, difficulty doing even basic daily tasks such as sitting up from sitting to standing, for example. And there's a great psychological impact as well that patients will go through. This overall kind of trend towards muscle wasting and lean body mass loss, which ultimately is sarcopenia, this will have a negative impact on patient outcomes, including the patient performance status and fitness for treatment, suitability for treatment, the treatment toxicity and the risk of complications when they're on treatment, function and independence, so just being able to do things as independently as possible, quality of life, and it impacts overall survival and prognosis. So as dietitians, when we're seeing patients, there will be an individualized plan according to the patient's, their particular goals. But underpinning all of this, we'll be looking at some key nutritional goals, and these will be primarily to optimize nutritional status before and during treatment, and to ensure ongoing adequate energy reserves. So today we've been discussing the treatment options available for cholangiocarcinoma, and really in summary, all of these will impact nutritional status to some degree, some more than others. So with chemotherapy and radiotherapy treatments, many patients have eating problems during and after their treatment. This is so commonplace. And nutritional interventions will focus on trying to help manage side effects and symptoms that patients are experiencing. So on the left here, we have the very common side effects, which I'm sure all of you are very familiar with. They can be different levels of severity. When patients are struggling nutritionally, the focus of nutrition really is towards supportive nutrition or supportive nutrition strategies. We would discuss with patients things like food fortification techniques, how to maximize energy and protein intake, how to make every bite count, and so that when they have a small appetite, how can they achieve the maximum amount of nutrition possible. We would consider all nutritional supplements if there's a place for these. For example, if patients aren't really managing on food first, we would need to add in additional measures to optimize calorie, protein intake, etc. There are options for enhanced nutrition support. So this is usually used when patients maybe are admitted to hospital for various reasons. Practical advice on specific dietary adjustments can be given, and that's a lot of what we focus on. So, for example, if patients have nausea or a sore mouth or throat, we can advise on specifics around adapting diet. And even small things like advising patients on the timing of antiemetics or analgesia around mealtimes. This can go a long way to minimizing the side effects they're experiencing and trying to make mealtimes more pleasurable. So with surgical interventions, just outlining here the possible options that patients may have or may undergo. But I wanted to highlight the Whipple procedure in particular, and there's a nice diagram here on the right-hand side. Really, the reason why I wanted to highlight this one is because it's the surgical intervention that will have the biggest nutritional considerations post-op. So with our Whipple procedure, we know it's a complex procedure. The key nutritional considerations here. So these can start pretty much straight after a surgery, but they can persist for quite some time afterwards. And it's really important to be aware of the ongoing impact of these issues. So delayed gastric emptying and gastroparesis is commonplace. There's a high prevalence after a Whipple procedure of pancreatic enzyme insufficiency, or PEI, and roughly 70 to 100% of patients will experience PEI post-Whipple. Again, diabetes can be another consideration after Whipple, depending upon the amount of pancreas removed, and uncontrolled diabetes or poorly controlled diabetes will render a patient unable to effectively gain weight or to thrive. So after a Whipple procedure, the symptoms can begin quite early on, but again, they can persist for weeks to months post-op. And we're looking at symptoms such as poor appetite, early or prolonged satiety, this postprandial effect where there's a lot of abdominal discomfort, bloating, cramping, wind, weight loss may be occurring, and this may be despite the fact that a patient is eating what seems like relatively okay, but they're still losing weight. And then diarrhea, steatorrhea, so this pale, fatty, oily stool, these symptoms may then begin. And this is actually quite a late sign of PEI, whereby lipase secretion is reduced by approximately 90% or more. So with these patients, we would recommend that they are commenced on pancreatic enzyme replacement therapy. There are capsules that are taken with all dietary intake to help effectively digest food, to promote better absorption and to minimize this malabsorption effect. It's important to consider early initiation of PERT in these patients and not waiting for these very late signs of PEI, because at this point the nutritional status is already significantly impaired. So with BAM, I want to talk a little bit about this today because, as I mentioned, it's often under-recognized, but it can be a consequence in patients, particularly those who have had any particular, systemic treatments or abdominal radiotherapy in particular. So back to basics, really, bile is produced in the liver, it's stored in the gallbladder, and it's released into the small intestine when food is eaten, and primarily when fat or protein are consumed. So in normal circumstances, 97% of bile acids are reabsorbed in the small intestine, usually across the small intestine, but primarily at the terminal ileum, and then they're returned to the liver via the enterohepatic circulation. However, when this cycle is disturbed or broken in some way, bile acid malabsorption will ensue. And it's thought that BAM will affect 1 in 100 people approximately in the UK. So the reason why it's often underdiagnosed is because it can promote sort of very generalized GI symptoms similar to PEI or even to IBS. And so often it's just put down to that rather than considering that there may be another consequence. So the causes of bile acid malabsorption, there's 3 different types. Number 1, where there is a problem with the terminal ileum, so where this site of absorption of bile acids occurs. And this may be due to inflammation or surgical removal. Type 2 is where there's no definite cause, so they can't really they can't identify what the cause is, and it's primary bile acid malabsorption. And type 3 is where there are diseases or conditions in the abdomen, so perhaps gallbladder removal, celiac disease, pelvic radiotherapy, so if patients had pelvic radiotherapy in the past, or chronic pancreatitis as well. So these can cause bile acid malabsorption. So due to the presence of these malabsorbed bile acids in the colon, there's a colonic sort of irritation that occurs, increased colonic motility, and this will cause quite a high frequency, watery or even fatty, pale, greasy diarrhea that can be quite problematic. This may also be coupled with bloating, cramping, abdominal pain symptoms, and excessive wind. So if you've got a patient who is potentially taking pancreatic enzyme replacement therapy and they're getting these symptoms, they may just be increasing their dose of PERT, thinking that they're underdosing, that they're not adequately matching their PERT with meals. But in this situation, if it is BAM, there will be no improvement with increasing doses of PERT. And so this would begin to raise sort of red flags for me that potentially there's another reason for it. So ideally, to help diagnose if BAM is a problem, a patient should be referred to a gastroenterologist for full assessment. And the main way of diagnosing is via CCAT scan to determine the retained or reabsorbed bile salts in that person. In actual fact, what usually happens is because CCAT scans can be difficult to access for a lot of patients, they'll often be placed on empirical treatment if the likelihood of BAM is high, and then it's almost like an assessment to see will they improve symptomatically with the addition of treatment for BAM. So in terms of what the treatments are, so the first line really is medication, so your bile acid sequestrants. So we have cholestyramine, cholestyramine, cholesevelam, and these may be prescribed in addition to anti-motility agents such as loperamide or codeine phosphate. The issue with these medications, with the sequestrants, is that they are quite difficult to tolerate, and patients don't really do very well with them. The compliance can really be quite poor. So this needs a lot of attention. If you are starting patients on bile acid sequestrants, always double check the full compliance, because it really can be variable. Another mode of treatment is dietary adjustment. And we know that dietary fat restriction is effective in managing symptoms of BAM in borderline across to severe BAM as well. So across the spectrum of BAM, this approach can be quite effective. The diet can be restrictive, so because we have to restrict fat to less than 40 grams per day, and so this can have a knock-on effect in terms of adequacy of intake. So it is really important that this approach is taken with the guidance of a specialist dietitian to oversee sort of nutritional adequacy. So another condition I'd like to discuss a little bit about is small intestinal bacterial overgrowth, or SIBO. And this is caused by the presence of excessive bacteria in the small intestine. So the risk factors for developing SIBO overall there's a number of them. So firstly, reduced gastric acid secretion. Any condition where there's reduced intestinal motility, this may be due to previous surgery whereby adhesions have developed, maybe after radiation therapy or after multiple abdominal surgeries. This can often happen. Damage to the small bowel wall due to the localized effects of chemotherapy or radiotherapy. And interestingly enough, this can happen, SIBO can happen even quite some time, having had chemotherapy or radiotherapy and completed treatment. This can still occur months down the line. If patients have had gastrointestinal surgery, for example, a Whipple procedure, or maybe a biliary bypass of some sort, or removal of the last part of the small bowel, this can predispose to a risk of SIBO as well. So the symptoms of SIBO, again, we're seeing another sort of similarity here, these bloating, flatulence, chronic diarrhea symptoms, weight loss, malabsorption, nutritional deficiencies such as B12, and osteoporosis. So these symptoms can range from mild to quite debilitating for patients, and there's a high psychological component and emotional impact here due to the nature of the symptoms. Patients have a lot of gas, and they fear sort of being out socially or in any kind of public places, and it can really impact quality of life quite significantly. And again, I don't think it's often considered in oncology follow-up clinics or in general. So treatment for SIBO, it's primarily antibiotics, so patients may go on to rifaximin. It's usually a 10 to 14-day course. Dietary management includes correction of nutritional deficiencies. If there's a transient lactose intolerance, we may look at that with patients and sort of helping them to make some dietary adjustments. In certain situations, a low FODMAP diet may be indicated, but only where patients are perhaps eating relatively well and maintaining weight, because low FODMAP can be relatively restrictive. Again, we would look at appetite and sort of manage any appetite-related issues, because when there's a lot of gut symptoms going on, the automatic reaction for a lot of patients is to stop eating or to try and restrict intake, to try and manage symptoms, and that really is ultimately harmful to their nutritional status ongoing. And so we try to tackle these issues alongside the actual symptoms themselves. Again, to emphasize that dietetic input and support is recommended here, and that when a treatment is implemented, to retest, to redo that breath test to see has there been any improvement after treatment, and to see sort of has it been effective. Thank you.
My name's Erica. I'm 53. I've got 2 teenagers at home, and one of them has flown the nest. I work in an insurance company. I'm just like anyone else, really, except I've got cholangiocarcinoma. It's a rare type of liver cancer and one of the toughest ones to treat. My care team reckon I've had it for years. Getting diagnosed was a terrible shock to the system, for me, my husband and my kids. I'd had some pains in my stomach, but I didn't think they were serious. By the time I saw an expert, it was too late to operate. A few months ago, I didn't have any real worries, but now my life feels so uncertain. But my doctor tells me things are changing in cholangiocarcinoma, so I'm hopeful about the options that might be available to me.
Cholangiocarcinoma is a very aggressive cancer, and due to a lack of specific symptoms, it's often diagnosed late. This can make it hard to treat, and currently there are very few treatment options available for these patients.
My diagnosis came after a biopsy, like a big injection, except they take tumour tissue out instead of putting medicine in. It was just a small piece of me, but precious and incredibly important. It just may be a key to unlock new options for patients like me.
Molecular testing has become essential in the fight against rare cancers like cholangiocarcinoma. All of us have an increasingly important role to play. From ensuring enough tissue is taken during biopsy, to using it sparingly during diagnosis, to make sure there's enough left over for molecular testing.
My team were great. They've made that tiny bit of tissue go a long way. And now I'm waiting. If certain genetic changes are found in my cancer, it might make me suitable for new targeted treatments. So, well, fingers crossed.
The cells in our bodies are constantly dividing. Sometimes, when certain genes in the cells change and become faulty, for example, when mutations occur, it can drive the cells to grow out of control. This is how cancer is formed. In order to try to stop the cancer growing, these faulty genes have to be brought under control. This can be done by selecting the right treatment. Almost half of cholangiocarcinoma patients have genetic changes, which can potentially be acted upon. Molecular testing helps us to identify patients who have faulty genes in their cancer, and in turn, those who might benefit from targeted therapies that could significantly extend their life. And as more genetic alterations are being explored, we are creating a genetic footprint for the identification and treatment of the cancers of others in the future.
It's been a difficult time for sure. But knowing I might have a way to get a bit more time, that keeps me going. And even if I don't, it's nice how that little part of me has contributed to science. That it might help someone else like me in the future. That's something.
If you've been diagnosed with cholangiocarcinoma, ask your doctor about molecular testing.